Good day, everyone. Thank you in advance for your interest and openness to learn about a pressing public health concern raised by the WHO and the Department of Health. In the Philippines, 8 out of 10 eligible patients do not receive palliative care. A number of significant barriers have been identified and must be overcome to address the unmet need for palliative care. One of these is often the limited or non-existent training on palliative care for health professionals, especially now in the era of universal health care, which covers the complete spectrum from health promotion to palliative care. After completing this module, you should be able to recognize how your personal values and beliefs about dying and death influence your responses and interactions with people affected by life-limiting illness. Describe the core principles of palliative care and explore factors which inform decisions about who would benefit from palliative care and when palliative care is needed. To provide palliative care that is relevant, you need to understand the experiences, preferences, and care requirements of people affected by life-limiting illness. You will develop an understanding of the social and personal experiences of people with life-limiting illnesses and their families. This module will have no pre-test, but there will be 10 embedded post-test questions. Your responses will be recorded, and we shall provide you the results of these responses. We would like to introduce to you William. William is a 60-year-old man who grew up in a large family in a regional area of Australia, one of the forefront countries in the practice of palliative care. Over the years, like many of his generation, he has seen enormous improvements in the quality of health care and life expectancy. This is due to such things as the introduction of immunization, antibiotics, and new medical technology. William has also seen how family structures have changed over time. He has seen the introduction of home for the aged facilities to care for frail older people who were previously cared for by their families at home. He has seen government changes which have supported the introduction to care and support for people affected by life-limiting illness at home, in a hospital, in a hospice, and in a residential aged care facility, facilities that are almost non-existent in our country. Technological changes that have assisted with illness management, and advances in medication that have resulted in people living longer with life-limiting illness. William is concerned that he may be diagnosed with a life-limiting illness due to changes in his normal bowel habits. He has gone to his family physician for advice.
If you're not happy for any reason, just send it back within 30 days and we'll give you your money back. That's a 30-day risk-free money-back guarantee. So you've got nothing to lose. So what are you waiting for? Call 1-800-1...
That means this fella come over for the pipes yet?
Nah. Do you want a cup of tea?
Yeah, that'd be great though. I always thought I had good genes. Both my mum and dad lived until they were well in their 90s, so I thought, good outside chance I might live to a ripe old age too. That is until recently. I discovered that when I went to the toilet, there was blood on the paper and in the bowl. Now he wants me to go and have a colonoscopy. He wants to look up inside the bowel. It's a bit of a worry. You know, you don't even think about dying until someone sends you off for a test just like this one.
There you go, love.
Then you can convinced you're going to have cancer. You're not going to be able to do all the things you want to do with your life.
William said he thought he had a small possibility of living to a ripe old age and that he doesn't usually think much about dying. What societal and personal factors could contribute to William's belief and response to his illness? A. Scientific and medical developments. B. Demographic changes such as longer life expectancy. C. William's previous experience with death. D. William's age. And E. All of the above. Societal and personal factors that contribute to patients' beliefs and responses towards life-limiting illness are age, social, cultural, spiritual aspects, and previous experience with death and dying. Death is often viewed as something that happens in older age. This can make the death of younger people especially difficult to understand. It can also mean that older people who are dying may receive less support or attention because their death is expected. In social context, dying and death do not happen in isolation from the rest of life. We are influenced by how other people or groups respond to dying, death, and loss. In another dimension, the meaning given to illness, dying, and death in different cultures can influence how a person manages the experience. For example, culture can influence the family's role, communication patterns, or feelings of optimism or fatalism. Spirituality, on the other hand, can influence death rituals and beliefs about the afterlife. For some people, they provide a source of meaning. For other people, they can create a sense of conflict or distress. Some people have no experience with dying and can be fearful of what can occur. Others can be anxious about dying because of the negative experiences of someone they have known or heard about. 1 year later, after undergoing treatment for colon cancer, William visits his palliative care doctor.
Bill, you know from your visit to Dr. Maxwell that they found the cancer has come back in your liver?
Yeah, he said that.
What did Dr. Maxwell tell you about what happens from here on in?
Well, he told me that the treatment hadn't worked, and the chemotherapy wouldn't help me anyway. He just couldn't tell me how long I had left. I asked him, he said a few months.
Yes.
So what do I do now? Do I just wait around for something to happen? I've got so many questions. I mean, how much pain will I be in? Do I have to go into hospital? It's too much to think about.
Well, Dr. Maxwell has sent me the report and I've had a look at the scans. It's quite understandable that you have a lot of questions and a lot of concerns at this time. And it's also important to know that even though the chemotherapy is not going to help you very much at this point, there are a lot of other things that can be done. And I'll be working with a group of skilled health professionals to make sure that things are as good as possible for as long as possible. Would you like me to go through some of the options that are available to you at this time?
Yeah, that'd be good.
Yeah, we'd appreciate that.
Okay. Well, the most important thing is that everyone is an individual. But there are some things that can be predicted, some physical and emotional health problems that can arise. And it's important for us to keep a very close eye on you to identify those problems early and to try to prevent them if we can, but also to try to treat them as early as possible. Bill, is there anything in particular that's worrying you at this time?
Well, there's hard, really. I don't know. I'm worried about Gladys, how she'll cope, and how we'll manage once we get home and I get too sick.
Well, most people want to be as independent and active as possible for as long as possible. We can engage specialists in medicine, palliative medicine and palliative nursing to be able to help you and monitor your progress. They can also identify things and treat them as early as possible. With that kind of support, it is possible for most people to stay at home and be active for quite a long time.
Okay.
Well, that's better than I thought.
Yeah.
We'll be straight into the hospital or something. That's good.
On the average, using a scale of 1 to 10, how comfortable are you with breaking bad news and discussing death and dying to your patients or to the people around you? When it comes to breaking life-altering news, recent studies have shown that patients generally desire full and frank disclosure, though a sizable minority may still not want full disclosure. Focused training in communication skills and techniques to facilitate breaking of bad news has been demonstrated to improve patient satisfaction and physicians' comfort. Here's a quick guideline on breaking of bad news. 1. Prepare yourself. Be well versed with the case and the patient's background. 2. Prepare a conducive setting. Consider a quiet venue, proper timing, and determine the right people who will attend. 3. Check your patient's perception. What does the patient already know? 4. Check for the patient's readiness. Does the patient want more information? 5. Give a warning shot. Do not be blunt. It is vital to prepare patients and families for the difficult information you are about to share. These warning shots should be short, simple, and honest. Something like, "I'm afraid this is not something you would expect," or "This is going to be difficult for me to say." 6. Provide the requested information. Provide practical support. Listen to the patient's concerns before that of the concern of the family. Number 8, provide emotional support. Encourage them to ventilate their feelings. At the end, summarize and plan. Better yet, let the patient or the family articulate what they understood to ensure that you are all on the same page and how the action plan should move forward. Lastly, offer availability of whatever assistance is needed. Here's an open-ended question. What do you like or do not like in the approach of the palliative care doctor in this scenario? Briefly explain why. The doctor offered the services of palliative care. Palliative care is an approach that improves the quality of life of individuals and their families facing the problems associated with life-limiting illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and the treatment of pain and other problems, including physical, psychosocial, and spiritual. Does palliative care affirm life? A. Yes, it affirms life and regards dying as a normal process and a part of living. B. No, it hastens death. C. No, it postpones death. D. I am not sure. Palliative care is about living. It supports people to live their life as completely and as comfortably as possible in ways that are meaningful to them by focusing on living well, even with deteriorating health, ensuring that they have the best quality of life while they are alive. The intention of palliative care is not to prolong or shorten life, but to respect the natural moment of death. Let us define hospice care. It is used when a disease, such as advanced cancer, gets to the point when treatment can no longer cure or control it. In general, hospice care should be used when a person is expected to live about 6 months or less if the illness runs its usual course. People with advanced cancer or other conditions should be encouraged to have a discussion with their family members and doctor to decide together when hospice care should begin. Studies show hospice care often is not started soon enough. Sometimes the doctor, patient, or family member will resist hospice because they think it means giving up or that there is no hope. It is important to know that you can leave hospice and go into active cancer treatment anytime they want. But the hope that hospice brings is a quality life, making the best of each day during the last stages of advanced illness. On the other hand, end-of-life care is a part of palliative care, and it refers to the last few days of life when a person is irreversibly dying. Question number 5. Is palliative care the same as euthanasia? A. Yes, it is the same. B. No, it is not the same. C. I am not sure. Euthanasia is different from palliative care. Euthanasia seeks the deliberate ending of one's life to end suffering. Palliative care seeks the lessening of suffering brought by the life-limiting illness through symptom control. Palliative care provides relief from pain and other distressing symptoms. Many palliative conditions have complex symptoms and unrelieved symptom issues that can have a negative impact on a person's quality of life. People affected by life-limiting illness frequently experience a myriad of symptoms due to a combination of the illness itself, the illness-modifying treatment, and concurrent comorbidities. Palliative care enhances quality of life and may also positively influence the course of the illness by providing a support system to help people live as actively as possible until death. Palliative care improves quality of life by focusing on living well, even with deteriorating health. The following questions can assist to determine which area of their life the person with a limiting illness needs help and support with. Are they comfortable and pain-free? Are they able to socialize or spend time with loved ones and people who are important to them? Are they having as much independence as possible? Are they feeling that they are a burden to others? Are they feeling emotionally balanced? Do they have all the information they need at this time? Holistic care is a trademark of palliative care. Palliative care integrates the psychological and spiritual aspects of care. Palliative care treats the whole person rather than just the symptoms of illness in order to identify personal goals and preferences for care. It can assist with a variety of needs. The 5 domains of holistic care include the following. 1. Physical needs, the management of physical symptoms such as pain, weakness, fatigue, and dyspnea. Information about treatment, diagnosis, or prognosis. 2. Psychological and cognitive needs, the management of psychological symptoms, financial concerns such as loss of income and medical costs, legal concerns such as preferences for end-of-life care and advanced care directives. 3. Social needs, need for social support, and need related to language and information disclosure preferences. 4. Spiritual needs, spiritual and existential concerns including hope, loss of meaning, and uncertainty. Cultural needs, unique cultural and personal experiences are considered when planning the care. William has now developed significant pain from his liver metastasis, and his family physician has referred him to a specialist palliative care service. The specialist team keeps in close contact with the family physician and his community nurse. William and his wife are talking to the community nurse and discussing his current needs. Having assessed how he's managing physically, the community nurse recognizes that William is becoming less mobile and is increasingly fatigued. The community nurse begins to explore with William and his wife future options for care as his illness progresses and he becomes more physically frail.
So can you just tell me how things have been going for you both since I last saw you?
Yeah, not too bad, Linda. My appetite's still lousy and I'm in a bit of pain, but you were right, those tablets take the edge right off it. Yeah, but I don't want to take that liquid morphine anymore. It makes me too drowsy.
Thanks, Gladys.
I'll just put it on that table.
Okay, so you've had some problems with your appetite and some problems with your pain.
Yeah.
The GP, has he been contacting you regularly?
Yeah, well, I sometimes feel the need to move my medications around a bit, so I just call up the office, make an appointment. Girls are great. They just always seem to be able to fit me in.
Did they keep contact?
Yeah, well, there was that social worker came by last week. She showed us the legal documents to fill in when I get to the point where I can no longer make decisions for myself.
Now, I wanted to talk a bit more about your pain and appetite problems, but is there any other sort of things you want to talk to me about today?
Yeah, well, look, I'm unsure as to whether I should go into the hospice or the hospital when the time comes when I can no longer be managed from here. Hospital's closer, but everyone says the hospice is great and all the specialists are there on tap, so I just don't know what to do.
Have you and Gladys discussed it together?
Yeah. Look, I want to stay at home, of course, but the kids have all got their own families and they mostly work full time and none of them live nearby anyway, so I think when the time comes I should be looked after elsewhere.
Well, there are a few things we can do. One thing we can do is to increase your services here at home to, try and help you stay at home here.
Right.
But, if something comes up out of left field where you're having problems, you can go into the hospital or into the palliative care unit and hopefully get that sorted out and then possibly come back home again.
Cheers.
We don't normally think of our own dying experience, but at least for this time, I request you to reflect. What is quality of life for you in your own terms? Complete the statement by choosing all that apply. My life is only worth living when I can talk with my family and friends. I can wake up from a coma. I can live without being hooked to machines. I can be free from pain. I am not causing any burden to my family or loved ones. I am not sure. When is the best time to refer to palliative care services? A, early in the course of the diagnosis of a life-limiting illness. B, when treatment outcomes are poor after maximizing medical treatment. C, at end-of-life care. D, when patient requests for it. E, any of the above. Palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy. And it includes those investigations needed to better understand and manage distressing clinical complications. Early identification, impeccable assessment, and comprehensive management of physical symptoms are central to the provision of high-quality palliative care. Even small improvements in symptom management can significantly improve quality of life. Early engagement with palliative care emphasizes active, comfort-focused care and a positive approach to reducing suffering. It improves quality of life, helps to avoid burdensome interventions of low benefit, and reduces hospital admissions. Furthermore, early referral to palliative care allows building rapport and meaningful engagement with the patient and family as well. Palliative care offers a support system to help the family cope during the illness and during their own bereavement. Let's have another case. This time, we introduce Emily's story.
You're feeding the dog, Ryan.
No, I'm not. I did it last night. Yeah, but if you do it last night, then you do it in the morning as well.
Ryan, you're feeding the dog.
Yeah, right. Okay.
Jacob, can you get upstairs, clean your teeth and get ready as quickly as possible?
Okay.
But I gotta eat my breakfast.
After you finish your breakfast then, okay? Emily had a really, really bad night last night. She's a lot paler than usual this morning. She's really keen to go to school today, but this breathing, it's got me really worried.
Yeah, she's not looking too good. You're breathing a bit hard today, Princess, eh?
I'm going to have to take her into town to see the doc.
Yeah, okay, love. Look, that heifer's got him at Darren's paddock again. You right to take the boys to the school bus?
Yeah.
Yeah?
Yeah, of course.
All right, drive safe.
Okay, I'll see you this afternoon.
Love you, Princess. Boys, behave for your mother, okay?
Yes, Dad.
Righto. See you again, have a good
Bye.
day.
See you, Dad. Your fingers on.
Okay, boys. School bus is here. I'll pick you up. Usual time this afternoon, okay?
Okay.
Be good. See ya. You all right in the back there, darling? It's not going to be long. Yeah, not too much longer. Hi, Emily. Come on in and have a seat.
So, Emily, you sound as though you're having trouble breathing today.
I couldn't sleep last night. It hurts to breathe in too much. I really wanted to go to school today, but Mum said I'm not allowed to.
Emily has been going to school lately, but on Monday when she came home, she looked so pale and she just wasn't herself at all. Then by yesterday, she was having trouble breathing when she was talking. It's bad, like the last time she was unwell, but it just seems to have happened so much faster this time. She's using the oxygen like you suggested for when her breathing gets like this. And when she uses it, she does seem to be a bit better.
I'm glad to hear that the oxygen has helped. Emily, I see that you used your walker to come in today. Does that help with your breathing when you're walking for longer distances?
I have to walk slowly, and sometimes I feel dizzy.
Well, it's good that you found it helpful. Right, well, I think I'll have a listen to your chest. Okay. Emily, it looks and sounds as though your heart is having trouble pumping the blood around your body today, which is why you're having trouble breathing. I'll have a look and see what other medications we can try and use, and I'll speak with Dr. Greg from your cardiology team. I think I'll also speak to another team in Brisbane. They work specifically with children, and we'll see if we can help with your shortness of breath. They're called the Paediatric Palliative Care Team.
I know the palliative care team. That's just for old people. Like Grandma in the hospital before she died.
Well, palliative care teams work with people of all ages, not just when they're dying. They help you to do the things that matter to you when you're getting more unwell. You remember a while ago I spoke with you about how one day your heart might not be strong enough and we might need some additional help to keep you comfortable. Well, Emily, we're worried now that you're getting sicker more often, and we know your heart is getting weaker and weaker. Together with the Brisbane team, our aim is to keep your heart working as well as it can and to keep you comfortable no matter what.
Does this mean that we're going to have to drive to Brisbane? Because I don't think Emily can handle that drive, and Robert is just so busy, and then there's the boys and the farm. And
I can speak with the teams in Brisbane by organising a meeting via the computer, just like everyone's there in the room with you. For now, I think it's important that you stay home from school and keep using the oxygen when you need to. I'll give you a call after I've spoken to the teams in Brisbane, and I'll organise a time for you to speak to Chenoa. She's the nurse with the Paediatric Palliative Care Service. She's in a similar role to Hannah, but for palliative care instead of cardiac. Chenoa and the doctor with the team are incredibly knowledgeable and they love working with kids. I think you'll find them to be a great help, and you can ask them any questions you may have. I know this is a lot to take in, but, well, how do you feel about that as a plan?
Okay. We should just make it back in time to pick up your brothers.
Can you hear me, Margaret?
Oh, hello. There you are. Well done, Hannah.
Oh, great.
Can everyone see and hear us all the way out there?
Oh, we can hear you loud and clear.
Hi everyone, and our thanks for agreeing to meet with us today with myself, Di, our Director of Nursing, and Alan from the Royal Flying Doctor Service to discuss Emily's case today. I'm very keen to hear any suggestions you may have about Emily's management and ongoing care.
Good morning, Margaret. I believe you know Greg and Ben from Paediatric Cardiology Team.
Hello.
Yes, hello again.
And I'd like to introduce you to Chenoa from Paediatric Palliative Care Service.
Thanks, Hannah. With me here today is Amanda, our paediatric palliative consultant, and Twen, our social worker.
Hi.
Hello. Amanda, would you like to take it from here?
Hi, Margaret. I am sorry to hear that Emily is unable to have more surgery and that she's not able to have a heart transplant. Now, as you know, our team would like to work with you and the cardiology team to give her the best quality of life we can, and also to support the family as much as we can. Now, one area we'd like to focus on is pain management and other symptoms. Are any of these an issue for Emily?
She's having increasing difficulty breathing.
I see here that Emily already uses oxygen at home when she's breathless. Does Emily also have a portable oxygen cylinder that she can use when she's away from the house?
Well, Emily had an exacerbation of a condition about 6 months ago, which is when we first ordered the oxygen. Her breathlessness seemed to settle down for quite a few months after that. I was surprised at how soon it is now since her last episode. She's recommenced using the oxygen this week with moderate effectiveness. I would like to organise a mobile oxygen cylinder because they mentioned on their visit that it helps Emily when she uses the oxygen. She has 2 large standing cylinders because they live out of town and often rely on a generator or solar power. I know Emily's keen to get back to school to visit her friends. It would be helpful for the palliative care team to connect with her school about the care of the oxygen equipment.
What about Emily's parents? How are they coping with things?
Emily's parents own a large cattle property out of town. Robert works 7 days a week on the property, And Melissa's had to take a job in town 2 days a week to help them financially. They also have 2 other children, Jacob and Ryan, who are 6 and 8 years old, and they can be a bit of a handful. Emily's had quite a bit of time away from school lately, and I know that Melissa's been helping with her schoolwork as well. When they came in yesterday, Melissa looked tired and physically run down. To be honest, I don't know how Dad is coping. I never see him. And I rarely get the chance to ask Melissa when she brings Emily in to see me, well, even how she is managing with all of this, to be honest. I would really like to assess this properly and see if we can provide some support financially as well as emotionally.
Margaret, I will talk to Shanoa and Hannah. We will discuss what further assistance and financial support might be available. It is often what we see. As you described, the dad is busy trying to financially support the family, and it can be difficult to get his perspective. We can connect with them at home with an adults-only conversation to explore some of their shared and individual concerns.
Margaret, have you had a conversation with Emily and her family that her condition will deteriorate? I realise this can be difficult to do, and she may have periods of stability, but it is likely that they will see a steady decline. The time frame we're dealing with in terms of life expectancy is still uncertain. As you know, with complex heart disease, it's possible that Emily could have a cardiac episode or even an infection, such as influenza, within the next 12 months and not recover. It will be important now to manage both her physical symptoms, such as pain and shortness of breath, as well as provide practical and emotional support. It would also be a good idea to discuss a plan about what to do if Emily should have a sudden deterioration. This could include a sudden worsening of her symptoms as well as an arrhythmia, which could lead to a sudden decline and possibly even sudden death. We've developed a resuscitation plan to assist with this discussion and would be happy to share it with you. And again, I acknowledge this will be a very tough series of conversations for you to have with the family.
Yes, it's a very difficult time. I mentioned to Emily and Melissa that I would be including the Paediatric Palliative Care Service in her care and explained what that means. Emily was upset by this. I explained to her what you do as a service. I haven't spoken to them directly about Emily's condition deteriorating and what that may include, but I'm sure they're very aware of it. I have found it hard to discuss. I'm not really sure what to say to them. From the things that Emily's been saying recently, I think she knows she's going to die, but she doesn't seem to want to talk about it in front of her mum. I get the same feeling that Melissa doesn't want to admit it in front of Emily.
Yes, it is hard to discuss, but it is an important conversation to have. It is actually not uncommon for parents or children to understand the seriousness of the illness and know that death will happen, but they just don't like discussing it. We will set up a family meeting online with you, Emily and Melissa. We would like it if you could organise it so that Robert can be involved as well, and then we can all sit together and discuss what's likely to happen and what steps to take.
Well, that sounds like a great approach. And I'm sure we all look forward to meeting and planning together again soon.
Mum, have a look at the funny email that Shanoa sent me for my birthday.
Well, you don't turn 12 every day, do you? Well, that is a funny birthday message. Now, when you reply to Shanoa, tell her thank you and tell her that we've spoken to your teacher and we've organised for you to visit your school friends tomorrow. You can go in your wheelchair and we can attach the portable oxygen.
Mum, there was also a birthday card from Pop today. Do you think Grandma's looking down from a star, wishing me a happy birthday too?
I'm sure she is, darling.
Go away, rat.
Family members or friends who take on the role of principal caregiver are often stressed and can benefit from support. This support can include which of the following? Choose all that apply. Keeping the family informed about what is happening, explaining what to expect and how they can help, ongoing education about care and management, managing expectations, support during decision-making on end-of-life issues, provision of emotional and spiritual support, preparation for death when this is imminent, support after death and during the bereavement process. Palliative care uses a team approach to address the myriads of needs of patients. Palliative care uses a team approach to address the multiple needs of patients and their families, including bereavement counseling if indicated. People affected by life-limiting illness often have complex and multifaceted needs. In order to be effective, palliative care should be provided by a range of health professionals, trained volunteers, family members, and carers. Not all people will need specialist palliative care. Clinicians who have advanced training in palliative care deliver specialist palliative care services, which includes providing direct care to people with complex palliative care needs and providing consultation services to support, advise, and educate non-specialist clinicians who are providing palliative care. This interdisciplinary approach enables collaborative and person-centered care. This can assist with care goals that are unlikely to be achieved by health professionals when working in isolation. There are many factors that determine the type of palliative care a person needs, and the type of services that they require can change throughout their illness. Generally, there are three broad groups based on the complexity of individual needs for palliative care. A key factor influencing the type of service required by people with life-limiting illnesses is the intensity of their needs. The straightforward and predictable needs. This group comprises people whose needs can generally be managed through their own resources, including with the support of family, friends, and carers, and or with the provision of palliative care by their existing healthcare providers, including general practitioners, community nurses, geriatricians, oncologists, medical specialists, and other health professionals. People in this group do not usually require the care delivered by specialist palliative care providers. Under intermediate and fluctuating need, this group includes people who experience intermittent onset of worsening symptoms, such as unmanaged pain, psychological distress, and reduced functional independence that can result in unplanned and emergency use of hospital and other health services. People in this group may require access to specialist palliative care services for consultation and advice. They will also continue to receive care from their existing healthcare providers in whichever care setting they are in, such as in the community, hospital, or in a home for the aged setting. And lastly, complex and persistent needs. This group comprises people with complex physical, psychological, social, and other spiritual needs that are not able to be effectively managed through traditional primary care methods. People in this group can require more ongoing direct care by the specialist palliative care providers. However, this care should occur through partnerships and shared care models with primary care providers and can occur across all care settings. Here are some key concepts to consider. All people affected by life-limiting illness have a right to health care that is appropriate to their needs. Not everyone with a life-limiting illness will require access to a specialist palliative care service. For many people, care needs can be met by community and personal resources and the support of primary or aged healthcare services. As a healthcare professional, you are likely to encounter people in a variety of settings who may benefit from palliative care. All healthcare professionals, therefore, need knowledge and skills in providing this type of care. People living with a life-limiting illness will need to have palliative care provided in many different settings. These settings can be divided into two broad settings as represented in the diagram: community-based or hospital-based. Community-based settings include people's homes, residential aged care, accommodation for people living with a disability or mental ill health, correctional facilities, general practices, and community palliative care clinics and day centers. On the other hand, hospital-based support can be inpatient, palliative care beds, other inpatient beds, outpatient services, specialist rooms, intensive care units, and even the emergency department. A person's level of need for palliative care services may be influenced by issues associated with the person's health needs, 2, the personal resources and strengths they can draw from. Different settings of palliative care services may also impact on a person's and their family's quality of life. Let's have some reflections on what we have learned so far. It is essential for all healthcare professionals to develop the capacity for reflection and self-evaluation of their professional and personal experiences and consider how this impacts themselves and others. Consider the module you have just completed and reflect on the following questions to assist with your ongoing development. What specific strategies do you plan to incorporate in your own practice as a healthcare professional? Cite at least 2. Do you see any difficulties using what you have learned here as part of your practice as a healthcare professional? If so, what strategies can you use to address these difficulties? Let us start translating into practice the insights we have learned. May we be instruments of facilitating access to our patients in need of palliative care. Thank you very much for listening.